So, Dr. Sinclair, we have a picture here that's showing multiple microaneurysms at the level of the capillaries in the retina. Why is it so important to pick these up? And what do we tell the patient that has these?
Okay, these are very important, more important than we've realized in the past. Before, when a doc would look at a fundus and say, oh, you have some microaneurysms, come back and see me in 6 months with diabetes. But now we're recognizing that these early microvascular abnormalities that are occurring are now recognized to be small blood vessel occlusions. And this is the early demonstration of VEGF, vascular endothelial growth factor, that makes in these areas of relative ischemia the relative local proliferation of endothelial cells. So you get outpouchings that produce these microaneurysms with small areas of leakage. And
Can you point to them just
sure.
so people could
So
see?
here's one here, here, here. And when you compare these against the standard fundus color image, you can't see these at all. But when you use yellow to blue-yellow wavelengths, about 580 to 590, you can see these beautifully. And we're now recognizing that you're seeing, so I don't know whether this area here, this is a microaneurysm that's starting to fibrose around the edges of those endothelium. So we're recognizing occluded and fibrotic and all of these changes to the microaneurysms that are going on with this progressive diabetic process, early with the oxidative stress injury, and then all of the early VEGF and cytochrome C and all of these different interactive mechanisms that are activating the inflammatory reactions all in these areas. But then you come back to me and say, well, Steve, so what is this causing in terms of the patient? And what we're now realizing is it's early neuronal injury, apoptosis and death, and focal defects in the visual field. And you don't see so much right in the fovea, which is really interesting because, well, there are no microvascular changes that are less so here, but these become progressive as you move away. So these are still within the central field and still causing defects when we analyze them early in the visual function process.
And what does this relate to endothelial dysfunction and the endothelial cells? Does that mean that the endothelial cells are starting to break down inside the blood vessels?
Exactly. That's what I'm saying is the endothelial cells are dying and I'm sorry, or separating and allowing fluid. So there's microvascular leakage and endothelial slight swelling, but you're also getting parasite swelling. And what that combination does is it narrows the capillaries and with the stimulation of what are called VCAMs, vascular endothelial attraction molecules, these make leukocytes plug those capillaries. So this is the earliest stages of capillary occlusion along with capillary leakage and evidenced by these little microaneurysms.
And if you look at the blood vessels, especially at 6 o'clock, you can see that white streak. And
Exactly.
does that go along with atherosclerosis that we're seeing there?
Yes, it's sclerosis of these vessels. So we're getting macrovascular disease and all the things that have been identified for the past 20 years in the diabetic macrovascular process. But look, it's not only with the arteries and streaking here that you're seeing, but look at what's happening with these large veins as well. We're getting some sort of plaque deposition in those as well. What is that causing in terms of the eventual dilation of these vessels and the alterations of those vascular components?
And this could happen even before the fasting blood sugar goes up or the A1C goes up. Just the insulin may be up, as from our paper that we published on insulin resistance. So when we see people like this, we need to definitely find a way to change their lifestyle so they don't be, if they're not diabetic yet, they're on the spectrum of becoming diabetic.
I agree with you entirely, Kerry. We need to put these cameras into the general diabetic clinics, and we need to, and AI has not only has to derive the outcomes here and the risk prediction, but it's got to educate the practitioners about these things so that we can educate the patient then about their lifestyle and what it's causing. And we have to coordinate the care between the optometrist, the ophthalmologist, and those general physicians, so that we always are focusing on, well, what can we do for the retina itself with micropulse laser or antioxidants or things of that sort. But we also, you're right, we need to control the insulin resistance and the hyper regulation of those glycemia.
So if we're seeing very early signs of endothelial dysfunction, does that mean that this person at some point is at risk for a heart attack or a stroke or some kind of vascular accident, and that we're picking it up very early in the eye?
Yes, we are. And a lot of the population-based studies have shown increased risk prediction. But again, how do we interpret this for the doc and the patient that we can intervene? Because what everybody's saying, oh, well, that's 5, 10 years, 20 years off. I'll worry about it then. No, we have to do preventive early stage treatments because the risk is there. You're absolutely correct.
Well, thanks a lot for that. And we'll move on to the next slide. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Microvascular, the only supplement with the exclusive patent on all 3 macular carotenoids and Microvascular technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not
right,
multifocal.
exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. Welcome back to part 2 of my interview with Dr. Stephen Sinclair. In part 2, Dr. Sinclair explains how the eye can show early signs of cardiovascular disease. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows.
All right. So here's something which is, it's the same thing I showed you before, but a little bit more aggravated. So you see big cystic changes, but look at this drilled, disorganized inner retina ischemic lesions, and look at the outer plexiform layer here that's swollen all up and with a droll outer retinal, and the same thing here. Look at this outer retinal power. It's no longer clear in the transmission through, and it's due to, we think, more and more and more now, this ischemia, reperfusion injury, oxidative stress. And all I can say is from this one here is when they had several experts. Oh, and you know what an expert is, don't you? Okay. Okay, I'm a literalist. X is an unknown quantity and spurt is a drip under pressure. So if they get a number of experts to look at this and say, show me what you think are the drills and the drolls. There's all kinds of disagreement because look at all of the aspects of the lesion going on here. Yes, the retina is thickened. Yes, there's ganglion cell thickening. There's no cystic collection here, but there's all kinds of ischemic and neuronal dysfunctional apoptotic swelling injury.
And all those little dots that we see in the retina that we're seeing, all these little dots. You know what they are?
No, we don't. Are they collections of some sort of exudates are leaking from the blood vessels? But we're seeing them over here where, well, are they leaking from the outer retinal plexus, or are these neuronal, or are these amyloid, are these some sort of apoptotic injury products? We don't know.
So if we see a normal, basically a normal OCT, and then we start to see some of those dots, are we starting to say, well, that's a very early sign that something bad is starting to happen?
Yes. If you start seeing irregularities or this swelling, like here's a very small DROL, outer plexiform swelling and haziness and change here. And oh, by the way, I saw this as, so this is a dark lesion on autofluorescent. Let's just say it's a dark lesion. So a lot of those dark lesions that I showed you with the infrared and red scanning, are those ischemic lesions in the outer retina? Because I just thought, well, maybe there's some sort of pigmented or something, but we don't know what these outer retinal dark lesions are. But we're now starting to understand that they do represent significant pathology. And what's interesting in this study that went on, it was associated with cardiac arrhythmias. So this drool, these outer segments that were observed in the retina were associated with cardiac abnormalities. So it could be the neurons and soma within the cardiac atrium that's conducting down to coordinate the atrioventricular contractions. But we're also now realizing the same process that is going on in the retina that we're realizing is drills and drolls and these apoptotic lesions are going on in the myocytes of the cardiac muscle as well. So we're now realizing that cardiac abnormalities are not just large vessel occlusions, but they're small vessel abnormalities, occlusions and stuff that we're going to see, that we're seeing in the retina, that we're also witnessing in the cardiac conduction abnormalities and contraction abnormalities.
Just go back to those ripples for a second.
Okay. Yes.
The ripples, the slide after that.
This one?
I'll keep going.
Oh, to go down, you mean?
Yeah, right there, to the ripples, back to the other side. So over there are the ripples, and those are associated with cardiovascular disease. And there was actually a study that showed that if somebody has that, they're at a 6 times greater risk of having an event within 10 years, cardiovascular event on the atherosclerotic cardiovascular score scale. So those are these little ischemic spots in the retina. This is brand new information, hot off the press, that is showing that the eye doctor, if they see this, they can predict that you're at greater risk for cardiovascular event, that you're going to need to see your cardiologist, maybe have a calcium score or an echo or whatever workup that the cardiologist wants to do. But this is a very early sign that you're at risk for AFib, or that you're at risk for having an event, either a stroke or a heart attack.
Okay, but I'm going to say even more. We're now starting to realize that viewing the heart on an echocardiogram or something, you're not seeing how well the conduction, the transmission to go through to coordinate those contractures and the actual ability. So we're starting to realize the heart is suffering from microvascular disease as well as the macrovascular disease that you just pointed out.
So,
Okay.
Dr. Sinclair, when we see this, what do we tell the patient?
I think that we're seeing some significant microvascular things, whether it's associated with their diabetes or whatever. So we've got to think about risk to your heart and the brain as well with Alzheimer's and these other things. So you need interphysician referral and understanding across the board so that we can now start to analyze this and treat them better systemically.
Great, thank you.
And this just doesn't go on. We keep it too focused. Oh, we see it in the eye, but we don't, as you said, refer on.
I think it's interesting how they call it ripples because it looks like a ripple. You know, it looks like a ripple in the water. So I don't know how they were able to plan that out to make it look like a ripple in the water, but that's what your eye doctor could be seeing. And now we're going to show changes that could happen with Alzheimer's, that we can see early changes in the eye. And this is also cutting edge, very interesting findings. And as time goes on, we're going to get better at seeing these ripples. We're going to get better seeing these changes in the eye that may be associated with Alzheimer's. So could you tell us about this and what the eye doctor could be seeing?
Okay, this is just going to be very quick, but what I'm saying is that, again, what studies have shown when they've looked at pathologies of retinas in patients with Alzheimer's, or whether we're actually looking at images in living patients, we're seeing deposition in the autoreflectance images of amyloid deposits, both in the inner retina here and in the outer retina. What you're seeing here is what looks like, oh, that looks like a drusen deposit there in the outer retina. But they've actually shown that these are amyloid deposits. And they're now starting to see some thinning of the choriocapillaris, the choroid and choriocapillaris. But this is just only beginning as we're developing better methods of OCT imaging. Okay.
So to go back for a second on the cardiovascular, I mean, there's over 800,000 people, almost 1 million people a year in the US have a heart attack, and 12% on their first heart attack will die. So it's very important to pick that up. And looking at this slide with vascular changes with Alzheimer's and amyloid plaques, you know, there's some controversy about amyloid plaques, and I'd like to get your opinion on this, because they used to think that, you know, if we get rid of amyloid, we could decrease Alzheimer's, but the drugs that decrease amyloid doesn't get rid of Alzheimer's. That now they're thinking that the amyloid may be a protective mechanism to try to protect the nerve tissue. And I'd like to hear your opinion on that.
Well, it's just my opinion of this is that we're poor at separating. We thought that, well, you have a genetic predisposition and certain genetic abnormalities of Alzheimer's that leads to these products that are deposited. But we're now realizing that there's a significant proportion of microvascular Alzheimer's. And so how do we separate? Because the imaging and the analysis of focal Alzheimer's and the functional abnormalities is very poor. And the imaging is improving in the living human, but it still is very poor. So the problem is, what drugs are most appropriate for applying to retard, slow down, or try to prevent Alzheimer's is really dependent a lot, I think, on what we're going to be seeing more so in the retina in terms of the vascular. Because look at this. These are retinal vascular abnormalities that are seen with Alzheimer's. So what we're seeing here is defects, little focal defects in the microvasculature of the retina, and that these also are seen not only in the inner retina, but they're now concentrating a lot on the peripapillary blood vessels and how these, because we're now realized that it's the choroid which is actually supplying the capillaries for the axons of the ganglion cells that go through there, through the optic nerve then to the brain. So it's the choroid actually that is supplying these nutrients to those blood vessels, as well as now we're starting to realize that all of those glutamate and toxic byproducts of the metabolism of the retina, especially the outer retina, we used to think, oh, well, that's just taken care of by the veins. We're now realizing diffuses maybe out through that choriocapillary, through the laminar cabosum. So how well is are the blood vessels supplying that and controlling that and preventing the nerve fiber layer loss that we're now glaucoma is recognized to occur significant percentage of patients with Alzheimer's.
So on that OCT angiography on the left that you're showing,
Yeah,
we have these little focal capillary dropouts. So
right.
Is that fair to say those are little areas of ischemia or loss of oxygen where the blood vessels are being plugged up and they're starting
Yes.
to drop out? And can we take a step further and say this is happening in the brain?
Yes, this is what they've now done with actual studies looking at the pathologies of patients with Alzheimer's. They're seeing the same process going on in the brain. Yes, sir.
Beautiful. Can you go back to the amyloid one? Because if we're taking photographs of the back of the eye, we're doing images, and we see peripheral drusen, can we say that's drusen? Can we say that's amyloid? Can we say that person's at risk for Alzheimer's? Can we say that to the patient, or we're not there yet?
We're not there yet. We are recognizing that macular degeneration occurs with a high percentage of Alzheimer's patients. But being able to separate out, is this due to microvascular, is this due to amyloid deposition and stuff? We're just, the imaging is just, I'm hoping it's going to come along fairly quickly, but not quite yet. We've got to improve the vascular aspect so we can define, oh, you have a microvascular type of Alzheimer's, you have an amyloid genetic type of Alzheimer's, you have a this or a that. I'm hoping we're going to be able to go there.
But go back to that one more time, because I want to talk about this study and I want to get your opinion on it about amyloid. There was a study done at Cedars-Sinai in Los Angeles, and they showed that amyloid plaque predicted atrophy in the hippocampus, and that the retinal amyloid correlates with cognitive scores. Now, they used a technique using a laser ophthalmoscope with curcumin to light these things up.
Right.
I'd like to have your opinion on that.
Well, again, this is a new imaging methodology that potentially can visualize, visualize these plaques. And yes, they are associated with the focal aspects, but I think this is going to require a lot more differentiation rather than trying to group and look at percentages and stuff. We're trying to differentiate these different causes of Alzheimer's. I think that's where we're going to go.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
And one of the problems, and I think, in the future it's going to be worked out, but a lot of this is non-specific. So it could be for Alzheimer's, it could be for glaucoma, it could be for kidney that we're going to show, it could be for hypertension. So it could be for it happens in a lot of disease states, just to show how similar a lot of these disease states really are.
And again, it's to point out that the retina is the window for imaging these disease processes going on. Yes. And it's going to require not just the physician looking, but it's going to require all these different imaging modalities improving and the AI assessment of that. Because what I'm trying to show is that a lot of the times when we look at pictures, such as this picture of this eye with hypertension, I mean, look at the blood vessel abnormalities.
Let me just interrupt you real quick, 1 second, just to go back to Alzheimer's, because I want people to know there's almost 7 million people in the US with Alzheimer's, And
Yes.
they're projecting by 2050 that there'll be close to 13 million people with Alzheimer's.
Yeah.
So this
All
is
of these with the aging population and these microvascular diseases that are going on. And again, I'm going to talk a lot about pre-diabetes because everybody says, "Oh, well, you don't have diabetes. Your hemoglobin A1C is low enough that we don't have to." No, a significant portion of this blood vessel abnormalities are occurring, but we'll come to that. Okay.
And if you do find that you're at risk, I mean, it takes like 20 years for these diseases to occur. I did a very good podcast with Dale Bredesen on preventing Alzheimer's and maybe even reversing. So go back and look at that one. So now talk to us about hypertension and some of what's happening there.
Okay. Well, again, we've recognized that hypertension alone, even without diabetes or other, is a risk factor in itself. And again, what we're seeing is a huge perfusion pressure coming into the eye and the limited ability of the small arterioles to control the blood flow in the eye. And so with this hypertension, microvascular insult, what it's causing is inflammatory reaction. So yeah, we can see the large vessels, but what does this really mean in terms of I don't see any secondary retinal problems there. But when you look at the OCT angiography, what you see here is progressive over time, significant progressive accumulation of the small blood vessel infarcts. So there's a few little tiny ones here. And then as time goes on, you see that these accumulate more and more. So you're getting small microvascular occlusions.
So, and I just want to point out to people that are non-doctors that hypertension, this is all related. So hypertension, you have greater risk for cardiovascular disease, stroke, and also dementia. So all these things are related in some way.
Okay. Now, here, predominantly what we're looking at are the inner blood capillary defects. But remember that there are two layers of capillary supply from these inner hypertensive retinal blood vessels that you're trying to maintain autoregulation of blood flow. So when we look at the outer plexus, it's supplying the middle nuclear layer. Look at the defects also in these capillaries that are just outlined in red here just to show them better. So I'm saying we need to really think about multiple layers and how does this affect your vision? In other words, it's not just the ganglion cell layer transmitting the images to the brain, but in that middle nuclear layer as well, predominantly in the cones section in the center. How is it affecting your fixation and your focusing, your vision abilities? Okay. All right. You wanted me to also include some pictures of the retinal vessel microvascular occlusions associated with chronic kidney disease. So whether it's diabetes or other hypertensive or other microvascular abnormalities, again, what we're seeing in the retina now, we're focusing more and more on microvascular insults from these chronic systemic vascular diseases. So this is the normal retina, and look at the one with chronic kidney disease. Okay. And, I'm sorry, no. What they tried to do here was to say, if we control the blood vessels, hypertension better, can we reduce these microvascular occlusions? So what was interesting in this study to me was if we could treat the affecting microvascular pathologic causes, can we get revascularization? And this suggests that we can. Okay? So, but we've got to do it early enough in that disease process that we can get the normal, remember the glia submit inflammatory, we call them inflammatory, but they contain cytokines that induce revascularization. Some of that is VEGF, but we have to do it early enough and contain it enough and monitor it so that we get revascularization, not wait until the death and end stages where we get neovascularization that just grows all to hell. So that was one of the things that I wanted to point out here, is that with chronic kidney, and I don't know how well it does it in the kidney. I can just tell you that we can see some of this in revascularization in the retina. Okay.
And you brought up before the GLP-1s, people are taking them for weight loss, they're taking them for diabetes. Tell us what the GLP-1s do, the Ozempic, the Mounjaro, that people are being prescribed now to either lower blood sugar or weight loss.
Okay. Yeah. Again, the GLP-1 receptor agonists are realize that this is a secondary effect, is to reduce that oxidative and inflammatory component. But does it do it alone? We have to go all the way back to that signal. No, it only changes one pathway. So it's limited in terms of its effect, but it does have this secondary effect. Whereas the SGLT2 receptor blockers and the TPVP also have some effects. So they've been predominantly prescribed for normalizing the blood sugar, but they do have this secondary anti-inflammatory effects.
So Januvia, Onglyza, the DPP4 inhibitors have shown to show some improvement in retinopathy beyond what some of the oral agents have shown. So
right.
Explain how that, I don't know if we know why that happens, but if you could explain why you think.
Well, again, it's a similar to the GLP-1 or receptor agonist. It does reduce some of the secondary inflammatory effects that are produced. But again, we've got to treat the retinopathy early enough. Those studies did it predominantly with intermediate or moderate or severe retinopathy, so the amounts of improvement were limited.
So let's go to alpha lipoic acid. Alpha lipoic acid is shown to prevent apoptosis, decrease inflammation. Right. Show us how that could be helpful if we could get that into the blood-brain or the blood-retinal barrier.
Well, again, we'd have to go way back up to that slide, but alpha lipoic acid predominantly effect is in the mitochondria and in that oxidative reduction in the reactive oxygen species. The great thing about alpha lipoic acid is when it's absorbed by mouth, it goes directly into the bloodstream and it passes through the blood-retinal, blood-brain barrier without any problem. But the second one that I wanted to combine it with was, say, benfotiamine, because benfotiamine also has had a significant amount of demonstrated anti-inflammatory effect.
That's
but when it's
vitamin B1, is that correct?
Yeah, exactly. It's thiamine. Yeah. But when it's absorbed by down in the gut, it's converted. It has to be converted, and its penetration through the blood-retinal barrier is not that great. So I'm thinking that if we really want to do it, the better way we would do it would be to maybe combine these and put them through a topical drop or a nasal inhalation so that we could get them into the retina better, into the brain barrier, but then you don't have the systemic effects on the kidney and the heart muscle and et cetera. So, but we've got to think about all of these in terms of those antioxidants and attacking it with multiple mechanisms.
And how about berberine has been shown to lower blood pressure?
Yeah, berberates, the crotins and berberates, these two, but again, they have less evidence, let's just say. So we need more evidence, but we need to really think about combining these mechanisms because they have a different effect on these things. So we need multiple effects because this is a conglomerate of a lot of processes that are affecting forward and backward. Okay.
Foods with alpha lipoic acid like red meats, carrots, beets, spinach, broccoli. How about that? Or
benfotiamine, yeah.
Foods with that like trout, beans, sunflower seeds yogurt.
Hey, I try to do this thing, but I got to get rid of my fat, and I got.
And how about taking just regular supplements? You don't think it'll penetrate the blood?
Oh, no. They will. Alpha lipoic acid will. Benfotiamine does, but much less so. So we've just got to think about how can we penetrate the blood retinal and blood brain barriers, because these are additional barriers toward getting these antioxidants in there. Okay.
And I sort of remember the audience, we're not giving people advice. Go always see your doctor.
Yeah.
And how about food? Do we know any foods that have it other than turmeric?
Oh, geez. I'll have to go back and look. It's just the vitamin and the health food industry and stuff, they promote these things like crazy, but show me the evidence. That's what I want to see.
And I know turmeric has berberine in it. So
okay, let's go through real
Yes.
quick, just a couple more things. Okay. So look, so this is a patient with just a focal leakage from the subretinal choroid. And, most people say, oh, yeah, there's subretinal fluid there. But look here at the middle nuclear layer as it goes into the area with subretinal fluid. It's all thickened here and layered. So there's all kinds of changes here that most of the time people don't pay attention to. Look at the thickening of this. So what's going on in the neurons and the microvasculature and the health of these, besides just the loss of the pigment epithelium here. And we recognize with this chronic fluid, even though this subretinal fluid looks pretty clear, it does cause chronic loss, retraction, and death of the pigment epithelium. So these are things that we need to analyze better, think about. Okay. Same thing with
pigment epithelium. What's its purpose in the retina?
Well, the pigment epithelium does several things. It's the primary source from the choriocapillaris of the blood retinal barrier, but it encapsulates the rod and cone outer segments. So we have to think of this as those rods and cones, because of the chronic light injury and everything, they are shedding their outer segments into that pigment epithelium. So they have to be gobbled up by the pigment epithelium, digested, and then expulsed through Brooks membrane into the choriocapillaris. The pigment epithelium has to do all of those functions. So besides supplying the metabolites for the functioning of those rods and cones, it has to extrude those rod and cone outer segments.
So the pigment epithelium is made up of melanin, and it filters the light, and it's protection. So does it make sense that the more melanin you have in the pigment epithelium, the more protection you're going to have?
Yes.
So people that are dark skinned that have more melanin, they're at maybe a lesser risk for certain diseases where the RPE or retinal pigment epithelium is filtering light and protecting the neuronal cells in the eye.
Absolutely. Yes. And so it is predominantly the fairer skinned race that either because of the genetic abnormalities of that pigment epithelium or the rods and cones develop macular degeneration. But we're also realizing, as I said, this macular degeneration occurs with a significant frequency in patients with other neuronal degenerations. But the reason I wanted to put in these slides was
real quick. I just want to ask you this, because people are going to be thinking this: is there a way to increase melanin in the RPE? Is there any way to do it theoretically?
There are melanin drugs. I'm blanking, Carrie.
Okay. I don't know the answer to that myself, but it's just something that I know there's some peptides that increase melanin in the skin.
Yes.
Take some peptides to get a better tan. I don't know if it'll increase it in the RPE though.
I don't know.
So, but food for thought anyway.
Okay. Anyway, just very quickly. So when we take the standard fundus photographs of patients, older patients, and with the exploding population aging, we're seeing a huge increase in macular degeneration. So it begins as these deposits in the outer retina that we call hard and soft, big and small drusen. So here you see a picture of it. And for the most part, we said, well, your vision is fine. Don't worry about it. It may progress. And if you see changes on an Amsler grid or something, you call me back, or they see them once a year. But when we're doing OCT, although we're now recognizing there are different types of drusen. So there's 3 steps, remember, to digest, to sucking up those rod and cone outer segments, digesting them within the pigment epithelium, and then extruding those digested components through Bruch's membrane. So those 3 components we're now recognizing. When 1 or 2 or 3 of those fail, we get 3 different deposits. Okay? So in this first picture, you see here a picture of subretinal drusen. The material is softer, clearer, or more opacified. But look here at what is ignored are the alterations of the pigment epithelium on the surface. Whoa, sorry. Okay. So here are deposits on top of the drusen, on top of or within the pigment epithelium, as well as abnormalities and swelling of the pigment epithelium itself, not paid attention to before.
And can you see the rod and cone layer there? Can you point that out?
Yeah. So the rod and cone, well, this is rod and cone, and this is the pigment epithelium on the surface. But I said, look at how the pigment epithelium is thinned out in certain areas and thickened in others, and the rods and cones are all abnormal as well.
And that rod and cone, the ellipsoid zone, that
Yeah,
I could tell
it's missing in some areas, and okay, here.
That's an indication of progression, or if that's damage, right?
Yes, yes. And look over here where you have all kinds of deposits that are on top of the pigment epithelium in the subretinal space. So these are called subretinal drusenoid deposits. And when they have certain kinds of configurations, like you see here, we call them ellipsoid drusen, okay? But what I'm trying to point out here that's not paid attention to is, look at the middle nuclear layer swelling and thinning of the outer plexiform layer. So there's all kinds of, and loss of the ellipsoid zone. Look at this, okay? So all that I'm saying is we're seeing all kinds of defects, but how are they related to vision abnormalities? And what is their risk for progression? How do we monitor or treat that progression are the important aspects that we're just beginning to now recognize that there are different types of drusen, different types of associated rod and cone abnormalities, and even middle nuclear layer bipolar abnormalities that are associated with this.
Now, is that the picture on the left? Is that more of a dominant drusen, a hereditary drusen?
On the left, yeah. Yeah.
On the left or on the right?
Well, they're both. They're both inherited drusen, but they're different deposits. And with all these secondary effects that I'm pointing out, that we've got to start paying attention to.
And go over with us which defects are most likely to progress.
These are the ones that are most likely to progress. The ones that are above that are not just a deposit in drusen, or sorry, in the RPE or under the RPE. The ones that are above the subretinal drusenoid deposits seem to have a more severe effect on the photoreceptors, leading to photoreceptor atrophy and progressive geographic atrophy. These. Here, 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 here. Okay? Okay. So I just put this in here because Ben Franklin, who was in Philadelphia, was a patient of mine. And so I was trying to talk to him about, gee, where do we have to go with detecting these things? And so we have to improve the OCT angio acquisition time so we can get better effects of looking at the not just at the occlusion of blood vessels, but we have to look at the flow within those blood vessels and the diameters and those parasite and endothelial abnormalities better, as well as the revascularization. Because if we detect this early enough and we get appropriate revascularization, that's good, maybe for some of those interretinal defects. I think we need to stop getting the patient in once every 6 months to measure their IOP. We're now recognizing that there are major fluctuations in the IOP as well as your blood pressure. And now we're realizing even in the venous pressure, because we used to think that, well, the blood flow comes in through the ophthalmic artery, so we just measure that pressure, and we just measure the IOP because the veins, once it goes out, it just has to be just higher than the IOP. But we're now realizing there's a new syndrome that's been sort of described in the past few years of Flommer's syndrome, in which, for reasons we don't understand, the venous pressure is significantly elevated. Is this because there are abnormalities of the veins as they try to go through the lamina curbosa, or affected by the choroidal vasculature there, or what's going on? We don't know. But I'm just saying we need to better develop ways of measuring all of these pressures so that we can understand glaucoma, retinal vascular diseases, all the ones we've talked about. We need to do the multispectral imaging, just like I showed you, where we're seeing not only the interretinal layer abnormalities and the microvascular, but we need to see these outer retinal and even the choriocapillaris abnormalities. We need to develop those, just what you point out with the curcumin staining of the amyloid B plaques, so we can understand that aspect better. And the whole process that I'm been trying to push is that we need to be able to better detect through imaging and functional testing, but imaging that will detect the neuronal apoptosis, not after the cells have died and atrophied. And that's what the OCT layer thickness is showing us now. It's just the cells have died and atrophied. But we need to be able to detect those neurons while they're dying.
So does the ERG help us with that?
Yes, it does.
You can tell us
But
why.
how often do you do ERGs in your office all the time?
Oh, we don't do them all the time, but I do them.
I'm just kidding here to say we need to be able to detect these in our general multi-million population that's aging with diabetes and degenerate and Alzheimer's, etc. in a way. So there are new ways. So one that I'm sort of involved with is we can now develop. It's what started as an intravenous injection, but now they're evaluating and finishing the animal studies to show topical, because it is absorbed through the blood-retinal barrier, so we can stain the neurons during the apoptosis.
I mean, I've had, going back to macular degeneration, I have had great success with lutein zeaxanthin, mesozeaxanthin, and maybe you should get together with the company that makes that and see about coming up with a formula, maybe through nasally or a drop or something like that. But I've had tremendous success decreasing progression of macular degeneration. Also,
with early macular degeneration and with early diabetic retinopathy, the rates of regression are 50 to 60, even up to 70%. But the problem is, again, we discovered and we detected way too late, and then the rates with the DRCR or the AMD studies are very poor in terms of getting any kind of vision back. Okay.
Well, I just really quick, a philosophical question, because because in the study in the ARAD study, they say, well, if there's one drusen, you don't need to treat it because nothing happens, but they only looked at it for 5 years.
Yeah. And okay, so what I'm saying here is that we need to develop ways of imaging these lesions earlier and during the apoptosis process, and we need to overlay our vision analysis so that we can understand the functional abnormalities. So very quickly, because I'm limited in terms of the amount of time left. So we're doing now microperimetry with retinal cameras that will be able to stabilize so we can look at the defects over the lesions that we're imaging. That's good, partially, but still, we are analyzing with most of the microperimetry, parametric, Humphrey visual fields that are done. Most often they're done with photopic visual field analysis. And that's utterly wrong because those cones are the last that are involved. The rods, we're now realizing, are much more involved earlier. So I've invented the OmniField, which measures Landolt Cs. So the patient responds by buttons or a joystick to the positioning of the Cs. But those Cs can be presented in mesopic illuminance environments and with contrast that mimic real world conditions. So we can test a patient under real world conditions. The problem with chart testing, so here's a patient with an OmniField that shows a preserved area over the lesion. Okay, so he measures with the chart 2040 to 2050. But the problem is he's sliding his eye around the chart. So chart visions that we've used now for almost 200 years are a very poor way of measuring vision because patients just move their eyes around the chart to find the best functional area. So the problem with this guy is he has a left retinal defect. Okay, all right, okay. So he has a right visual field defect that bothers his reading vision severely. So, you know, when we do a chart, we think, oh, he sees like that, like the picture in the upper left here. But this is his visual field. So it's interfering with his fixation abilities and motions, as well as his interpretation of associations within his field of view. Big cause of car accidents, et cetera, et cetera. Likewise, we're totally ignoring distortions in the vision. So if you have distortion in one eye and you overlay it in your binocular vision with the good eye, you see all kinds of, okay. Okay, so we need to do vision testing under real world conditions so that if that young lady or older lady wants to see that handsome dude across the table and visualize his facial expressions, or across the room under existing lighting, we need to really test that visual field and associations under those kind of conditions and overlay them on the lesion so that we understand the lesion detection and its monitoring and its treatment. How is that affecting the real world vision, not chart acuity? So if we want to see like my grandson here, who has a very contrasted suit, we can see him when he's hiking across the street. I don't know if I can see his the color of his chocolates there in his orange pail, but when I'm also looking at the backyard that we used to have in Philadelphia and being able to visualize all of the aspects, we really need to measure vision better and understand it better. And we've already talked about some of the treatments of antioxidants and acetylcholine resveratrol and the antioxidants that we've used for a long time for macular degeneration. I don't have a long time, but there's some real exciting evidence with micropulse laser that's applied in a continuous method across the posterior retina that seems to really have a natural rehabilitation ability of reversing these. But again, we have to find these early in the course of the apoptosis, not after the neurons have died and atrophied.
Yeah, I did a great podcast on micropulse laser for people that are interested. So
Oh, have you already done that? I didn't know it.
excellent podcast. I'll send that to you.
Glad to listen to it. I'm involved with it. I want to be more and more involved with it. I think
know
it's
you're
got some tremendous application.
I want to thank Dr. Sinclair. Is there any other things that you want to share with us? I know that you only have a minute or two left.
Yeah, unfortunately, I apologize for my time limitations. If anybody wants to hear more about it, look, my primary purpose in life, I'm seeing a lot of research now being done that I think is very appropriate toward understanding retinal, neuronal, and microvascular disease. But somehow we've got to get this out into the general population, not just in the research sphere. And we've got to educate physicians so that we've got to make the instruments tolerable and affordable. And we have to educate insurance so that these are paid for. And we have to educate patients so they understand, because of their binocular vision, they may not recognize that in the dim lights and stuff, their vision is that significantly affected. But we've got to treat these early so that we don't wait until the severe endpoints.
I want to thank Dr. Stephen Sinclair, MD, retina specialist, for joining me, inventor, for joining me today. If people want to find out more about you, how could they do that?
Well, my major site is Sinclair Technologies, but it's the LLC. It's not the equipment repair and stuff. So it points out a lot of the new instruments and things that I'm involved in. But certainly you can write me at Stephen H. Sinclair, but that's Stephen with a PH. My mom was old fashioned. PH Sinclair at iCloud.com.
Thank you, Dr. Sinclair, for joining me. You're a wealth of knowledge, and people are going to really learn a lot from this podcast. Thank you so much.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Microvascular, the only supplement with the exclusive patent on all 3 macular carotenoids and Microvascular technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.